Okay, so today we're really honing in on something that I know is super relevant to you guys out there, especially those of you working in ophthalmology.
Oh, yeah, definitely.
It's these orbital complications from infections, right?
Absolutely. A critical area.
And we've got some really interesting stuff to dig into. Like specifically, we've got some excerpts here on the Chandler-Huber classification.
Right.
And then, of course, the whole range of orbital infections that you deal with every day.
Right.
So, I mean, the goal here really in this deep dive is to sort of like, equip you with a much deeper understanding of how this classification works.
Exactly.
The key things that set these infections apart from each other.
Yes.
And how to manage them, because these are some serious conditions, right?
Oh, absolutely. Sight-threatening, potentially life-threatening.
Exactly. So we want to make sure we're giving you the tools to really tackle these head on.
Right. Provide a practical framework that you can use right away in your practice.
Perfect. So let's jump right in. Let's start with this Chandler-Huber classification.
Okay.
It seems to be like the foundation for approaching these infections.
It is. It's a really crucial framework for understanding these orbital complications that come from sinus infections.
Okay.
And it neatly categorizes them, into 5 distinct types.
Gotcha.
Which then dictates how we manage them and what we can expect, for the patient's prognosis.
So let's break down these 5 types.
Sure.
What are the key differences that, an ophthalmologist really needs to be aware of when they're examining a patient?
Okay. So type I, that's your preseptal cellulitis.
Okay.
That's where the infection is in front of the orbital septum, so just in the soft tissues of the eyelids and the skin around the eye.
Gotcha.
Type 2 is postseptal cellulitis.
Okay.
So now the infection's gone beyond the orbital septum, and it's actually involving the orbital tissues.
Okay.
Type 3, that's a subperiosteal access.
Got it.
So that's a collection of pus between the periorbita, which is that lining of the bony orbit, and the bone itself.
Okay.
Type IV is an orbital abscess where you've got a pocket of pus within the orbital soft tissues separate from the periosteum.
Gotcha.
And then finally, type V, that's the cavernous sinus thrombosis, which is a very serious condition.
Right.
It involves a blood clot in that cavernous sinus, which is a major vein at the base of the brain.
Right. Okay. So that really nicely lay out like the anatomical kind of distinctions between each type.
Exactly.
Let's delve a little deeper into each one, starting with type I, the preseptal cellulitis.
Sure.
I'm sure this is something you see pretty frequently in your practice.
Oh, absolutely.
What are the must-knows, like the essential things an ophthalmologist should always remember about this?
So preseptal cellulitis, it's generally considered less serious than orbital cellulitis in terms of, threat to vision and life.
Right.
But still really important to recognize it and manage it properly.
Of course, yeah.
And it's key to remember that it's confined to those structures in front of the orbital septum.
Okay.
So think of it primarily by what you don't see. You see a red swollen eyelid, but the eye itself isn't bulging or restricted in movement.
Right.
That's a strong indicator of preseptal cellulitis.
So the orbital signs are absent?
Exactly.
Okay, got it.
And while it usually stays localized, it can lead to complications like a lid abscess.
Oh, okay.
And in rare cases, it can even progress to, more serious things like meningitis or cavernous sinus thrombosis.
Oh, wow, okay.
We also have to be aware that it can quickly turn into orbital cellulitis.
So how does this infection typically start, and what are the usual suspects, like the bacteria involved?
So the most common ones are Staphylococcus aureus and Streptococcus pyogenes.
Okay.
And often it starts from something pretty minor, like a little cut on the skin around the eye or an insect bite.
Yeah, okay.
It can also spread from other local infections like a sty or an infection of the tear sac, conjunctivitis, or even a sinus infection.
Right.
Less commonly, it can be from hematogenous spread, meaning the infection traveled through the bloodstream from somewhere else, like an upper respiratory tract infection or a middle ear infection.
Okay, so various ways it can get started. And when a patient comes in with preseptal cellulitis, what are the key findings you're looking for in your exam?
Well, the hallmark is that swollen red eyelid.
Right.
It's often firm and tender, and it can look pretty bad.
Yeah.
But the key to distinguishing it from orbital cellulitis is that orbital exam.
Right.
So in preseptal cellulitis, you won't see proptosis, which is that bulging of the eyeball.
Okay.
And you won't see chemosis, that swelling of the conjunctiva.
Right.
And importantly, their vision, their pupillary reactions, and their eye movements will all be normal.
Okay.
They might have a fever, but those key ocular signs will be missing.
Got it. That's a very clear distinction. Very helpful. So when would you order imaging, like an MRI or a CT scan, for someone you think has preseptal cellulitis?
Typically, if it's straightforward and responding well to treatment, we wouldn't routinely do imaging,
Okay,
but we'd consider it if we suspected it had spread behind the septum, indicating orbital cellulitis.
got it.
We'd also want imaging if we thought there might be an abscess in the lid that needs draining,
Okay,
or if the patient isn't getting better with the initial antibiotics.
makes sense. So what's the usual treatment approach for preseptal cellulitis?
Generally, we start with oral antibiotics.
Okay,
A common choice is coamoxiclav,
okay,
and the dosage depends on how severe the infection is.
got it.
For more serious cases, or if they can't take oral meds, we might need IV antibiotics.
Okay,
And another important point, especially in your practice, is to always check their tetanus immunization status, especially if it happened after some kind of injury.
right. Good reminder. That's a great overview of preseptal cellulitis. That point about the lack of orbital signs is really key.
Absolutely.
Now let's move on to the more serious end of the spectrum, bacterial orbital cellulitis.
Right, so bacterial orbital cellulitis is a much more serious condition.
Yeah,
It's an infection behind that orbital septum, and it can really threaten vision and sometimes even life.
okay,
It can happen at any age, but we do see it more often in kids.
got it. So what are the usual bacteria that cause this type of infection, and where do they typically come from?
The common culprits are Streptococcus pneumonia, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenzae.
Okay.
And most often it starts in the paranasal sinuses, especially the ethmoid sinuses,
Oh, okay.
because they're so close to the orbit.
Right, makes sense.
But it's important to remember that it can also be a complication of preseptal cellulitis that wasn't treated properly.
Right, okay.
Or it can come from infections of the lacrimal sac, or the skin or teeth in the midface, and even after trauma, including eye surgery.
Okay.
And in some cases, bacteria can spread through the bloodstream from another infection somewhere else in the body.
Right, okay. So the clinical picture with bacterial orbital cellulitis sounds a lot more, well, alarming.
Yes.
What are the red flags, the signs and symptoms that should make you suspect this diagnosis immediately?
Well, patients with bacterial orbital cellulitis will often have a rapid onset of pain,
Okay.
and the pain is worse when they move their eyes.
Oh, okay.
They'll have significant swelling of the eye and the surrounding tissues, and they'll often feel unwell, have that general malaise.
Right.
And frequently, they'll have vision problems and double vision.
Okay.
They often also have a history of nasal congestion, sinus problems, or other respiratory symptoms.
Makes sense.
When you examine them, you'll usually find they have a high fever,
Okay.
their vision might be reduced, and they might say their color vision is off. And that's a big red flag because it could mean the optic nerve is compressed.
Right.
If they have a relative afropupillary defect, that's a very worrying sign.
Okay, and remind us what that is again?
Sure. So that's where the pupil actually dilates when you shine a light into the affected eye instead of constricting.
Right.
It's a strong sign that the optic nerve is involved.
Got it.
Their eyelids will be tender, firm, red, and warm.
Okay.
And there'll be swelling not just of the eyelids, but also around the eye and in the conjunctiva, which is called chemosis.
Right.
The conjunctiva will also be injected, meaning it's red, and you might even see a subconjunctival hemorrhage.
Okay.
Usually it's just one eye, but sometimes the swelling can spread to the other eyelid as well.
Right.
Proptosis, that's the forward displacement of the eyeball that's common in established infections.
Okay.
But it might be hidden at first by all the swelling in the eyelid.
I see.
You might also see non-axial proptosis, where the eye is not just pushed forward, but it's displaced in another direction.
Okay.
We call that dystopia,
Got it.
and that's more common if there's an abscess.
Right.
Painful ophthalmoplegia, meaning they have trouble moving their eye and it hurts. That's another key sign.
Okay.
And if you look at the back of the eye, you might see choroidal folds or swelling of the optic disc.
The pain and eye movement, visual changes, and proptosis. Those are the big three that scream orbital cellulitis.
Exactly.
Okay. Now, you mentioned differential diagnoses. What are some other conditions that could look like bacterial orbital cellulitis?
That's a really important point. We have to consider other types of infections in the orbit, like fungal infections or infections of the tear ducts.
Okay.
Then there are vascular problems, like a sudden bleed in the orbit or a carotid cavernous fistula.
Right.
Those can have similar symptoms.
Okay.
And we can't forget about tumors, especially in kids.
Right.
Some tumors can grow very quickly and look like orbital cellulitis.
Okay.
And there are endocrine problems like thyroid eye disease, especially if there's a sudden inflammatory flare-up.
Right.
And then there are non-infectious inflammatory conditions like idiopathic orbital inflammatory disease.
Okay.
Even severe allergies with a lot of lid swelling or shingles that affects the eye, those can sometimes mimic orbital cellulitis.
So a thorough history and a really careful exam are crucial.
Absolutely, to make sure you're treating the right problem.
Okay. Now, what are some of the things that can go wrong if bacterial orbital cellulitis isn't treated quickly and effectively?
Well, the complications can be very serious.
Yeah.
They can threaten vision and even life.
Okay.
In terms of the eye itself, we worry about optic neuropathy, which can lead to permanent vision loss.
Right.
And then there's exposure keratopathy, where the cornea gets damaged because the eye is bulging and the eyelids aren't closing properly.
Okay.
The pressure inside the eye can go up, which is dangerous.
Right.
And there's a risk of endophthalmitis, which is an infection inside the eye itself.
Wow.
And even occlusion of the central retinal artery or vein, which can cut off blood supply to the retina.
So really serious stuff.
Yes.
And what about complications outside of the eye itself?
Right. So within the orbit, a common complication is a subpterygosteal abscess, which is most often found along the medial wall of the orbit.
Okay.
And while less common, the complications that can spread to the brain are extremely serious.
Right.
These include meningitis, brain abscess, and cavernous sinus thrombosis.
That this is a real emergency situation. What are the essential investigations you need to do if you suspect bacterial orbital cellulitis?
When we suspect bacterial orbital cellulitis, we need to do a thorough workup.
Okay.
As with preseptal cellulitis after trauma, we need to check their tetanus vaccination status.
Right.
We'll also do blood tests, including a white blood cell count and blood cultures.
Okay.
These help us see if there's a systemic infection and try to identify the specific bacteria causing it.
Okay.
If they have a runny nose, we'll culture that too, especially since sinus infections are so often involved.
Got it.
But the most important test is a high-resolution CT scan of the orbit, sinuses, and brain. This imaging is crucial because it confirms the diagnosis.
Right.
It shows us how far the infection has spread, and most importantly, it tells us if there's an abscess in the orbit or the brain.
Right. That makes sense.
We can also use MRI in some cases.
Okay.
And if there are any signs that the meninges or the brain are involved, we'll do a lumbar puncture.
Okay, to check the cerebrospinal fluid.
Exactly.
So the CT scan helps visualize the soft tissues and any bone erosion, which indicates sinus disease.
Right.
Okay. So how do you typically treat bacterial orbital cellulitis? It sounds like you need to act fast and be aggressive.
Absolutely. It's a medical emergency.
Okay.
We admit them to the hospital immediately,
Okay.
and we get the ENT team involved right away because of the connection with sinus infections.
Right.
And we monitor them very closely.
Okay.
For children, we need to get a pediatric specialist involved immediately.
Right.
And in all cases, we have a low threshold for calling in an infectious disease specialist.
Okay.
Sometimes it's helpful to mark the edges of the redness on their skin with a surgical marker so we can see if it's spreading or getting better.
Okay. That's a good tip.
The cornerstone of treatment is IV antibiotics.
Right.
And the choice of antibiotic depends on the local patterns of antibiotic resistance.
Got it.
A common first-line agent is ceftazidime.
Okay.
And we might add oral metronidazole to cover anaerobic bacteria, especially if we think it came from the sinuses.
Right.
We usually continue IV antibiotics until they've been fever-free for at least 4 days.
Okay.
And then they'll need a course of oral antibiotics for 1 to 3 weeks.
Got it.
It's crucial to monitor their optic nerve function very closely,
Okay.
at least every 4 hours at first, by checking their vision, their color vision, how well they can see light, and their pupillary reactions.
Right.
If any of these get worse, we need to think about surgery right away.
Okay, so when does surgery become necessary?
Surgery is important in a few situations. If there's an abscess in the orbit, we often need to drain it early to relieve the pressure and get the pus out.
Okay.
If they're not responding well to the antibiotics, or if they have a bad sinus infection that isn't clearing up, we might need to surgically drain the sinuses.
Right.
If the presentation is unusual, or if we're worried about a rare cause, we might take a biopsy of the inflamed tissue to help us make the diagnosis.
Okay.
And as I mentioned, if the optic nerve is being compressed badly, we might need to do an emergency canthotomy and cantholysis to save their vision.
Okay. So again, the importance of working with the ENT team really comes through.
It does. That collaboration is key.
All right, let's switch gears now and talk about a much rarer condition, but one that can be really devastating.
Okay.
Rhino-orbital mucormycosis.
Yes. So rhino-orbital mucormycosis, this is a very rare and aggressive fungal infection,
Okay.
and it's often fatal.
Okay.
It's caused by fungi in the Mucorrhaceae family.
Got it.
And it's really important to understand that it usually affects people who have serious underlying health problems,
Okay.
most commonly diabetic ketoacidosis or other conditions that weaken the immune system, like after a transplant, or if they have a blood cancer, or if they've been on steroids for a long time.
Got it.
It's incredibly rare in people with a healthy immune system.
Okay.
The black eschar in an immunocompromised patient, that's a very specific sign that should raise alarm bells.
Okay, so how does this infection usually happen, and what makes it so dangerous?
Well, it usually starts when someone breathes in fungal spores,
Okay.
and that can cause an upper respiratory infection at first.
Right.
From there, the fungus can spread directly to the sinuses next to the nose,
Okay.
and then into the orbit and even the brain.
Wow.
The real danger is that the fungus can invade blood vessels, causing what we call occlusive vasculitis.
Okay.
Basically, it blocks the blood flow, which leads to infarction, meaning the tissues die.
That's scary. So how is rhino-orbital mucormycosis different from bacterial orbital cellulitis in terms of how it presents? Are there any kind of giving way signs?
Well, some of the initial symptoms are similar, like the swelling around the face and eye, double vision, and loss of vision.
Okay.
But mucormycosis tends to come on more slowly and gradually.
Okay.
A key sign, although it might not be there at the very beginning, is a black eschar.
Right.
That's a patch of dead tissue that's caused by the blocked blood flow and the fungal infection.
Okay.
This eschar can appear on the roof of the mouth, inside the nose, on the nasal septum, the skin around the eye, and even on the eyelids.
Okay, so that's a pretty distinctive finding. What are some of the complications of this fungal infection?
The complications can be really serious. You can have blockage of the blood vessels in the retina, leading to blindness.
Oh, wow.
Multiple cranial nerves can be affected as the infection spreads, causing various problems.
Okay.
And if the fungus reaches the brain, you can have a stroke.
So really serious consequences. What kind of investigations do you do? Is it similar to what you do for a bacterial infection?
The initial tests are similar.
Okay.
We'll do blood work and a high-resolution CT scan or MRI to see how far the disease has spread in the sinuses, orbit, and brain.
Right.
But to be absolutely sure it's mucormycosis, we need to take a biopsy from the affected area and look for the fungus under a microscope.
Okay.
Cultures are helpful too, but the biopsy is usually more definitive.
Got it. And the treatment for this fungal infection must be very different from how you'd treat a bacterial one.
It is, yes. Treating rhino-orbital mucormycosis requires a very aggressive, multi-pronged approach.
Okay.
The first and most important thing is to fix any underlying metabolic problems, like getting their blood sugar under control if they have diabetic ketoacidosis.
Right.
Then we need to start IV antifungal medications right away,
Okay.
and we need to be very aggressive with local treatment.
Okay.
This often means daily surgical debridement, where we remove all the infected and dead tissue. We also pack the area with antifungal medication and irrigate it regularly.
Okay.
We surgically remove all the dead tissue. We might need to do this multiple times
Wow.
in very severe cases. Or if it's not responding to treatment, we might need to do an orbital exenteration as a last resort.
And what is that exactly?
That's where we surgically remove everything from the eye socket.
Oh, wow. That's a major procedure.
It is. But it can be necessary to try to stop the fungus from spreading and give the patient a chance at survival.
Right.
We might also consider hyperbaric oxygen therapy in some cases.
Okay. Well, this has been incredibly informative. We've covered a lot of ground, and it's all so relevant to what you do every day as ophthalmologists.
It is, absolutely.
So just to recap, we started with the Chandler-Hubert classification, which is such a fundamental tool for understanding and categorizing these infections.
Right.
We talked about the key differences between cellulitis, which is more common but usually less serious, and bacterial orbital cellulitis, which is a much bigger threat to vision and life.
Exactly.
We emphasize the importance of a thorough exam,
Yes.
recognizing those crucial clinical signs, and acting quickly with the right investigations and treatment.
Absolutely.
And then we discussed that rare but very dangerous fungal infection, rhino-orbital mucormycosis.
Right.
We highlighted its connection with weakened immune systems.
Yes.
And the need for early diagnosis through biopsy and aggressive treatment with surgery and antifungal medications.
Absolutely.
This information is so important for you guys out there because recognizing and properly managing these infections can literally mean the difference between saving someone's vision and potentially saving their life.
That's right. Being able to quickly and accurately classify these infections using the Chandler-Hubert system and recognizing the subtle but important differences in how they present, that's essential for providing the best possible care and getting the best outcomes for your patients.
Absolutely. So I want to leave you with something to think about. We're seeing more and more patients with conditions that weaken their immune systems.
Right.
So how might that affect how often you see these orbital infections?
That's a good question.
And how might it change the way they present?
Yeah.
What can you do in your practice to make sure you're staying ahead of the curve so you can recognize and manage these complex cases and give your patients the best possible care?
It's definitely something to think about.
Absolutely. Well, thank you so much for joining us for this deep dive. We hope you found it helpful and insightful.
My pleasure.
And we'll see you next time on the deep dive.